We wait another minute or two and then we'll get going. Okay, I guess we have the full complement. Let me, can you guys hear me okay?
Yep.
Let me just welcome Tariq, who is joining us from Maryland today. He's going to be our first-year fellow soon. Some of you guys probably know that Tariq is completing neonatology fellowship. So welcome, Tariq, to our meeting. And it's very kind of you to come to the meeting. And he sent us a little chat saying thank you. Okay, why don't we get going? So this is during ablation case, and I'm asking the question that at this point the doctor is mapping an accessory pathway, and then something happened at the area where the arrow is pointing. So let me see, David Barris, what do you think's going on here?
So just looking at our leads that we have here, we have our surface electrograms, then our mapping electrodes at high right atrium, his, coronary sinus. You kindly provided an arrow pointing to AVF, where I see a positive deflection, and I'm kind of running down our electrodes and seeing where that comes from. It looks like his, actually, even before the arrow, there's something that's kind of a little, some sort of deflection in all of the leads as well, less prominent.
Let me just interject and say that the arrow is just pointing. It's not intended to point to it is pointing at the P wave, you rightly said, but that's not actually what's really being asked is what's happening in that, that sequence. But yes, please continue.
Okay, so now I'm kind of just looking down my electrodes. In terms of the first beat, I'm seeing the surface. Let me see here. The surface ECG looks like it's happening after all of our other internal leads, and then there's it looks like the PR interval on the surface leads on the next beat is far longer.
That's a good observation. I agree with that statement. Any thoughts on why that might be?
So, I mean, I guess Wenkebaking because of of increasing the
Cycle length of
the
pace.
cycle length.
Well, I guess I should have said it, that the pacing rate is fixed during this sequence that we're looking at here. We're not changing the rate at all.
So I mean,
What happens to the QRS? And like, let's look at this beat versus this beat. So you correctly stated that the PR interval seems to be quite a bit wider here than it is here, right? Here's the P wave, and then here's the QRS. So do you have any explanation for why the P and QRS look like this, but then look like this afterwards?
so it could be, I mean, it could be also loss of pre-excitation.
Yeah.
I mean, the mapping.
Yeah, that's exactly what that is, right? So sometimes it's a little challenging to understand the tracings because we're at 100 paper speed instead of the usual ECG sweep speed of 25. But in an EP study, this is the most common speed at which the signals are reviewed. And so what we see here is a short PR interval with a very wide-looking QRS. So this is a pre-excited complex. And then, as you astutely pointed out, the PR interval lengthens. The other interesting observation is that if you look at the signal in the distal ablation catheter, so presumably the person is mapping very close to the accessory pathway. So if you compare this signal to this signal, you see here that when the pathway is gone, there's a very clear small a and a larger V. You agree with that?
Yes.
Yeah, so the A is sort of on time relatively with the P wave, and the V electrogram on time. Remember that everything is happening in all the channels at exactly the same time, so you can use all the channels to help remind you or inform your thoughts about what is corresponding to what. And since this signal is occurring simultaneous with the QRS, it's clearly a ventricular electrogram. And since this signal is occurring simultaneously with the P waves, it's an atrial electrogram. So we see here in the pre-excited beat that the interval between the atrial electrogram and the ventricular electrogram is almost non-existent. In other words, they're sort of squished together. Whereas when the pathway stops conducting, the AV interval at the location of the pathway becomes very wide. So right when you're on the pathway, theoretically, you should see the earliest ventricular depolarization because you are closest to the first site at which the ventricle is being depolarized through this aberrant or unusual or extra pathway, accessory pathway. Well, once the pathway blocks, then it should no longer be the earliest. And in fact, I think you could, if you were to draw a line in your mind's eye from the V of the His, you would see that it is in fact earlier now than the pathway, than the ventricular electrogram at the location where the pathway was conducting. Whereas previously, the ventricular electrogram was far earlier than the His V. So normally, right, without an accessory pathway, the earliest ventricular electrogram should always be in the His catheter because that's the point from which the ventricle depolarizes, is through the AV node and His-Purkinje system. But when we block the pathway with, for whatever reason, or rather, so that when we have a pathway, the earliest V is always going to be at the location of the accessory pathway. And we're always looking, when we're mapping, for the location where the ventricular electrogram is the absolute earliest. And there are different ways to assess that, but generally the onset of the ventricular electrogram is compared to the onset of the QRS. And as a general rule, you would want to be 30 to 50 milliseconds before the onset of the QRS, which would be a generally good sign that you are in the correct location. And so, interestingly, radiofrequency current was not turned on in this patient on this tracing. This is what we would call a catheter bump. So during the mapping, the ablator touched the area of the pathway and it stopped conduction just from the force of the catheter touching it. Now, that is useful information and that it helps us understand where the pathway is, because clearly if just touching the pathway at this location makes it go from pre-excited to not pre-excited, that's probably a good sign that you're in the right place if it didn't even require energy to do that. And the hard part, though, is understanding exactly where did they go from here to here. It's clearly happened in a period of less than 1 second. So the nice thing about the CARTO electroanatomical mapping system is that it allows us to record where the catheter was at every beat of the heart. And so when this happened, we asked the CARTO representative to tell us where was the catheter when it looked like this, and half of a second later, where was it when it looked like this. And this allowed us to know the general vicinity very accurately of where the pathway was. Now, what we did was we waited for about 5 minutes until the pathway started to conduct again, because you would not expect a permanent dissolution of the pathway from a bump. And we were lucky in that it came back in just 5 minutes. And so we mapped in the area where the CARTO map suggested would be, refined the map just slightly to a position maybe 1 millimeter away from the two locations of these two beats. And we were therefore able to find the place and successfully ablate this pathway. So this is a nice example of so-called catheter bump. You also notice that the AV times are much tighter, for example, in the coronary sinus pairs when we're pre-excited than when we're not pre-excited, right? So similarly in the His. Now, this particular case, the operator doesn't have a His on their His catheter, but the bottom line is all of the AV times have lengthened out tremendously, presumably because the accessory pathway has been temporarily stunned by catheter touching that area. So I think this was a nice example of this. Okay. So this is an example of ventricular pacing in somebody. And I'm going to ask, let's see who we got here. I'm going to ask actually Uzo. So Uzo, we are ventricularly pacing somebody, and something happens in the tracing about 60% into the tracing. There is a change in the intracardiac signals, and I'm wondering if you can tell me what that is.
Okay, so we're V pacing, and I'm looking at the bottom channel where we're pacing the RV channel, and so.
So first, tell me what's.
So we're conducting. Sorry, I'm sorry.
Tell me what's happening in these beats here.
So when we pace the V, we're conducting retrograde in those earlier bits.
Yeah.
So we go VA, 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 and then let me see if there's a shift. And then around the middle, it looks like the VA, there's like, it kind of spaces out compared to, so if you look at the first 3 beats and we compare the VA conduction time, it seems to lengthen.
Yes.
For the second 3 beats.
I agree with you. So that's a very good, astute observation that suggests you've been going to EP conference, Dr. Obiaco. So what do you think happened there that the VA time like that? What happened in the MAP catheter?
So looking at the map, and same thing in the MAP catheter actually, it seems squished together. So same thing if you look at the first 3 bits in the map, it's all like the V and the A are like you really can't just make a distinction. And then it spaces out to later. So
right. So can you tell? That's absolutely right. So it looks like the accessory pathway was conducting and then stopped conducting.
And then stopped conducting, but we did not, I don't see any sign of any application or anything for us to see that we ablated the pathway.
So this is another
So
example.
this is another bump.
Yeah, this is a catheter bump. This is what we would sometimes call an inelegant ablation. Can you tell me where you think the pathway was, Uzo? Where do you think the distal ablation catheter is at the time that this occurred, based on the intracardiac signal?
So looking at the intracardiac signals, the earliest A seems to be in the distal CS.
Yeah, I think you might be right, right? So
It seems to be very close in the distal CS.
the V is small in the CS pairs, but the retrograde A is down here, right? And this A appears to be earlier than that A. But it's interesting that these A's, so just so everybody is aware, this is proximal CS and this is distal CS. So we're going from the mouth of the coronary sinus lateral to the distal coronary sinus. And we see that the ventricular-atrial time, which is very tight in the distal coronary sinus, all of a sudden it jumps out. And we see now, once the pathway is gone, that the earliest retrograde A is in the His, followed by proximal CS. And as we move more laterally, the atrial electrograms get later, presumably because we're going from the ventricle to the atrium via the AV node. In these beats, however, there is an accessory pathway. And so, as you correctly pointed out, this catheter, this earliest retrograde signal is in the coronary sinus pair. So how do you think then, how would you get to this area on the mitral annulus if you were doing this ablation, Uzo?
You would do a transeptal puncture to be able to ablate.
Usually you would do a transeptal puncture. Now, just for completeness sake, there are electrophysiologists who will do this using a so-called retrograde technique, where they go through the aortic valve and then they retroflex the catheter up across the mitral annulus and map in that manner. And there's actually a good long literature showing that that approach is essentially equivalent to transeptal approach. But I think in the present era, most electrophysiologists, though not all, would do this in a transeptal manner. And certainly here at Mount Sinai, both Dr. Love and I do these transeptally. So again, this is an example of a catheter bump. And again, because of this system CARTO, we were able to identify precisely where the catheter was, although one of the reasons, left-sided accessory pathway ablations are generally more successful than right, statistically. The success rate may be as high as 5 to 7% higher than right-sided pathways. There are a number of reasons for that, but one of the most important is that catheter stability is better on the left side. And probably one of the reasons that it's better, at least I think, is with a transeptal, the catheter is literally, the sheath is stuck in the septum. And that provides a lot of stability of the catheter and remember, of course, during an ablation, the heart is beating and is moving. And so I think that is one of the benefits. The other reason that I think that left-sided pathway ablations generally are higher success rates is that we have a coronary sinus catheter. And so we can see where the earliest signal is because the coronary sinus, which Dr. Walsh in Boston used to say was God's gift to the electrophysiologist, the coronary sinus runs on the mitral annulus. And so it allows us to very rapidly see where the earliest depolarization, antegrade or retrograde is, and allows us an area or at least a direction in which to target our mapping and then ablation. There is not an analogous structure on the tricuspid annulus. And so when we're mapping on the right side, we don't have the advantage of a coronary sinus catheter, which would allow us some information regarding where the earliest signal is. And so it's much more of a point-by-point type of map. Some electrophysiologists have advocated the placement of a very tiny microcatheter in the right coronary, which runs on the right AV valve ring. But as you would imagine, placing a catheter in the right coronary will potentially risk coronary occlusion, vasospasm, thrombosis. So there isn't a lot of excitement about the idea of putting a catheter there, even though it has been reported in the past. Virtually nobody does that. So some people have placed what they call a halo catheter in the right atrium to try and help have some kind of an analogous structure to the coronary sinus, but basically a left-sided pathway, although we do have to do a transeptal, which carries its own risks, albeit small, the benefit is that generally the success rate is higher. So in this case, again, the catheter never actually moved, as I recall, between this location and this location. And so, and that was confirmed on CARTO, where the catheter position was exactly the same on this beat as this beat. And so RF current was delivered and the patient was successfully ablated. Go to the next slide. All right, so following ablation, the patient is given 12 milligrams of intravenous adenosine, and this is an example of atrial pacing. And I'm going to ask Purna what's going on here.
Good morning, Dr. Pass.
Good morning, Purna.
So there is a block because we have given adenosine and we're pacing atrially, but it's not being conducted.
Right, so we're seeing all of the atrial depolarizations. We see P waves on the surface ECG, but no QRS. So this is the point where the doctor at the table is screaming to the doctor at the computer, start pacing the V. So this is, so Purna, why do we give adenosine in a WPW ablation? So we've ablated the pathway. We do not see pre-excitation. So why would we go through the exercise of giving adenosine if the patient who was clearly pre-excited previously is no longer pre-excited?
To make sure that the pathway is not conducting, to make sure that there is no residual conduction through the pathway. And basically, if you're blocking the AV node, there's a possibility for it to conduct through the accessory pathway.
That's
so
right.
It's like a checking mechanism.
Yeah, that's right. So it's essentially a way of confirming that there isn't even a small amount of pathway conduction underneath the AV node. In other words, we could, if we were close to the pathway, but not directly on top of the pathway, it's possible that we could injure the pathway without, as they say, killing it. And so by giving adenosine, we are blocking the AV node transiently in order to allow any possible conduction through the pathway to show itself. And this is often a good trick to more definitively prove that the pathway is no longer conducting. Now, there are many electrophysiologists who feel this is an unnecessary test because they feel like if you wait 20, 30, or 40 minutes, you'll eventually see pathway conduction and you don't have to use adenosine. But we found that this is kind of a nice confirmatory test. And I think it would be fair to say that most electrophysiologists still go through the exercise of giving adenosine in this setting after an ablation. Okay. All right, so this is from an ablation. This is the LAO fluoroscopy view. And I'm going to ask Sergey if you could tell me, where are the catheters? And I'll point one by one and you can tell me what you're thinking. So the first catheter I'm pointing to is this catheter here.
Is it high right atrium?
Yes, that's correct. This is a so-called quadrupolar catheter. It has 4 electrodes, so 2 pairs of pacing and sensing. Right, so this is in the high right atrium. Where is this catheter here?
This is probably a His catheter. Is it at the tricuspid annulus?
Well, no, this is an LAO projection. So in this projection, this should be roughly equivalent to the mitral annulus, and the tricuspid annulus would be somewhere over here.
The catheter that's parallel to it, I think, and going further up, I think that's the coronary sinus catheter.
Okay, so So this catheter with the multiple electrodes is actually the coronary sinus.
Right. And it makes sense because it has so many electrodes.
Right. And then this is a long sheath, which ends here where the radio-opaque marker ends. And then this is actually Dr. Love has taken the ablation catheter and gone all the way around the coronary sinus.
Oh, wow.
Okay.
I remember
It's
that.
a remarkable case. There's a wonderful case that Dr. Love did about some period of time ago. Probably our greatest ablation of the past year or two. And this is somebody who has what they sometimes refer to as summit VT or summit ventricular tachycardia, where it's coming from the sort of the base of the heart near, if you look on a CAT scan, the LV outflow tract, where these VTs can be arising from, is extremely close to multiple structures that are all rotating around. This is where understanding the 3D anatomy is very useful. But the VTs that are coming from this area can be approached typically retrograde in the LV outflow tract. Sometimes they can be arising from the coronary cusps themselves, specifically the left cusp. And so if you're going to ablate from there, you have to be very, very careful that you're not ablating near the orifice of the left main coronary, of course. And then it can also be addressed sometimes from the RV. Sometimes the RV outflow tract, if you remember, it's sort of rotating around the area of the LV outflow. So sometimes we can get it from that way. And then rarely, if you go way out the distal coronary sinus, you can also approach it. And in this case, that is how the ablation was performed, was that we ablated from within the coronary sinus because that was where the earliest signal was, and that was the effective location. Now, when you're ablating in the coronary sinus, there are a lot of special considerations, not the least of which is perforation of the heart, because it's an epicardial vein. So you have to be very careful not to give too much. Also, because there's not that much blood flow in the coronary sinus, the tip of the catheter will become very hot very quickly. So most ablation catheters are what we call temperature-controlled catheters, meaning that the operator tells the computer, I want the temperature to, say, hit a maximum of 70 degrees Celsius. But the problem in the coronary sinus is that because there's not very much blood flow, when you turn the RF current on, you'll hit 70 degrees very rapidly without almost any electrical power at all. And that's because there's nothing cooling the tip of the catheter. So typically, if you're going to burn in the coronary sinus, you need to use an irrigated catheter, meaning one that on the tip will spray saline to allow cooling of the tip, to allow delivery of greater power. Because when you're making an effective radiofrequency lesion, you need not only temperature, but you also need electrical power. Both have to be at a reasonable level. And so although you can reach a very high temperature in the coronary sinus, you do not reach a very high power. And so you have to use both. But when you're using an irrigated catheter, in general, they make much deeper lesions. So you have to be very careful when you're burning in this location, because it's one of those things where a little bit is good, a lot is not. And so in this case, Dr. Love, I believe, used about 20 watts of energy, and we were able to successfully ablate this focus, and was quite a remarkable case. And mapping was performed in all of the locations that I explained, the coronary cusps, the LV outflow tract, the RV outflow tract, and it was really in this location that we identified the very earliest signal. And the way that we got the catheter out here was first by injecting through the long sheath. We were able to show that the coronary sinus very nicely was quite large and was easily opacified all the way out to this area. And so we were able to successfully ablate it. Some patients in this area, the focus can be coming so deep within the ventricle that we actually need to, it may not be ablatable, or it may require strange experimental or investigational devices. There is, for example, a catheter, or it was, I don't think it's available anymore, that had a needle that you could literally stick the needle out so that it would go into the myocardium and you could deliver the current deeper into the muscle of the heart. To my understanding is that there are no further catheters of that nature. It actually proved to be somewhat effective and fairly safe, but I think ultimately, from what I've read, the manufacturers of that catheter decided there wasn't a large enough market to warrant making it. So, okay, this is a patient who has a history of SVT, and we are rapid atrial pacing in this tracing. So I'm going to ask David Barris to take a stab at what you think is happening here with the rapid atrial pacing.
All right, just taking a look here at our different electrodes, surface, then map, and then higher HM, his coronary sinus. Now I'm just looking first at, I guess, when our stim is coming in, and then following it to see what happens.
So just so you understand, so I'm telling you I'm atrial pacing, but you can actually tell by looking at the tracing, because you see this very sharp signal on the right atrial channel. That also in our computer, it actually tells you STIM1, S1, which refers to a straight drivetrain. But yes, so I'm sorry to interrupt you.
So it looks like just looking at the like the P to the A to V interval,
Right.
it looks like it's prolonged as we go along this this strip here.
That's correct. Right, because so some people might erroneously say that this pacing spike is conducting to this QRS, but actually it's conducting to the next QRS. And you are 100% correct, David, in saying that this is a very long PR interval. So what's happening is, as we're moving from the left side of the screen to the right side of the screen, the PR interval is getting progressively longer. And in fact, you notice that the pacing spike is actually starting before the onset of the prior QRS. You see that? So this spike is conducting to this QRS, and that spike is conducting to this QRS, and that spike before this QRS is actually conducting with a very long PR to that QRS. So this is an example of where the so-called PR interval is longer than the R to R interval. Does that make sense to you?
Yes.
And so when you see consistent PR interval being longer than RR interval, is there a terminology we use to describe that? Or is there any way that you could?
Is that a dual AV node physiology?
That's correct. So that's exactly right. And so when you see that the PR interval is longer than the RR interval in the setting of rapid atrial pacing, we would say that this is an example of dual AV nodal physiology. And so if you were to see that in somebody during your initial EP testing who has a history of SVT, then we would surmise, or at least wonder, if this patient has AV nodal reentrant tachycardia. Now, I've explained to you in the past that when we do EP studies, my general approach is to try to do the pacing sequences the same in every case. Not because there's anything particularly smart about the way I do my pacing sequences, but I just do it that way because I don't want to forget that I forget something. I always sort of do things in the same manner over and over again. And my general approach, once I've made sure that the atrial and ventricular catheters have a reasonable threshold, is to start with rapid atrial pacing. So this maneuver was probably done at the very start of a procedure on a patient with a history of SVT. And you can see that as early as the very first pacing maneuver, we have our first piece of evidence of what the patient has. So within literally 60 seconds of starting the EP study, we have, at least some reasonable indirect evidence of what it is that the patient has. So when we do EP studies, of course, we would reconfirm this by doing atrial extrastimulus testing, inducing SVT, and provocative testing. But we already have an idea as soon as the first maneuver. So each case is sort of like a onion where we're unraveling it and trying to get to the middle to figure out what exactly the patient has. And this is an example of how very early on in the case, we're able to have a pretty good guess about what the mechanism of tachycardia is right off. Let me just go to this one here. So this is a patient with arrhythmogenic right ventricular dysplasia. And Uzo, do you think there's something wrong with this tracing? Is there anything on the tracing that would help you in making this diagnosis?
So just looking at the leads, in one it had to, well, yeah, there's an upright pair. I was about to say it's hard to tell, but I think in the very first bit I see something there. But then just after the QRS,
Mm-hmm.
there's a deflection
Mm-hmm.
immediately after the QRS.
Mm-hmm.
Is this an epsilon?
Yes, that's correct. Very good. So blowing up V1, we see here that there is, I'll show it to you here in the 12 lead, but there is this little deflection called an epsilon wave. And it's said that an epsilon wave is found in about 50% of patients with ARVC or D. Now, again, so you can't, if you don't see an epsilon wave, it does not mean you do not have ARVC, but it can be seen. I think, quite frankly, that it is not seen in that many, but I'm not an expert in ARVC. I just have not seen this that much. It's a notch in the terminal QRS early ST segment, and it's thought to be due to slowed intraventricular conduction. So very good. So remember, ARVC has an epsilon wave, and actually, this is an example of it. So I thought something to keep in mind. You may not see this again, but one day, Uzo, you'll be reading a big stack of EKGs that someone has asked you to do as part of your job. And maybe one day you'll see this and say, I wonder if this patient has, it's usually in V1 that you see this. So it's V1 where you really want to look for the epsilon wave. And so I think I'm going to stop a little early here today. I appreciate your joining today. Hope you guys learned something, and I'll see you in just a few minutes at sign out. So have a good day, everybody.
Thank you.
Thank you,
Thank
Dr.
you.
Ross.